I would like to give you the mic now and to introduce the next speaker. Thank you
Thank
again.
you very much. Thank you very much, Dr. Saad. Thank you very much, my colleagues. And we will go now, we'll move on to the next session. Again, we'll go to the COVID-19, the man of the hour, as they said. It's a man of the hour, COVID-19. And I am glad to present for you our next presenter, Dr. Dear colleague anesthesiologist, Dr. Khaled Sarhan, lecturer of anesthesia of Cairo University, Qasr Al Aini Hospital. He is going to present for us ICU management of COVID-19 pregnant lady. Please, Dr. Khaled, you can start.
Well, thank you, Dr. Esmat, for this nice presentation for me. My talk will be about the intensive care unit management of a patient presented for COVID-19. Okay, I'm going to share my lecture now. If that's okay, I can proceed.
Dr. Khaled, can I ask you, Dr. Saad, to please stop my video so Dr. Khaled video will be clear? Thank you, Dr. Saad. Yes, please proceed, Dr. Khaled.
Can you hear me now?
Yes.
Okay. Bismillah ar-Rahman ar-Rahim. My name is Khaled Sarhan. I am a lecturer of Anaesthesia, Surgical Intensive Care Unit, and Pain Management in Cairo University. It's my first time to present in the that marvelous mega academy. And I'm very happy for this, sharing my knowledge and lecture with you. And I would like to thank Dr. Saad and all the members for that huge work, for their professionalism and patience and dedication. Okay. My talk is about the ICU management of the pregnant patient with COVID-19. Before we start the talk, we have to ask ourselves, do we have a good level of evidence about the COVID-19 in pregnancy? And to know this, we have to share the pyramid of the evidence-based pyramid. And as we know, the base of the pyramid is the lowest rank of evidence about the expert opinion and case series and case reports, and the top is the highest level of evidence about the this systematic reviews and randomized control trials. Where are we now? Actually, in COVID-19, in patients, in pregnant patients and in all patients, most of the evidence is coming from observational studies and case series and case reports. And so we have a very low level of evidence about the COVID-19. I'll start by the first question. Would the pregnant patient be more prone to COVID-19 infection or not? And the answer is coming from this retrospective study that have been published in the American Journal of Obstetrics and Gynecology. It was a retrospective study between March and April 2020. And they reviewed about 1,100 symptomatic patients with COVID, and only 82 female pregnant was positive for COVID, and that represents 7% of the examined population. And also, there were 82 of the pregnant patients out of more than 2,900 pregnant patients admitted. And so the incidence of COVID-19 in the pregnant patient was almost as the general population. And so it might not have an effect on the pregnant patient. Okay. The second question is, does the pregnancy impact the clinical course of the COVID-19? And let's move back to the H1N1 influenza pandemic in the United States between the 2009 and 2010. There were an increased risk of maternal mortality due to the H1N1 COVID-19 in the pregnant patients. And so there was a fear or a risk of increased maternal mortality due to COVID-19 as well. However, the early data from Wuhan, China, COVID-19 examination, they found that the incidence was almost comparable to the incidence about the general population. The incidence of pregnant with COVID, with severe COVID, was almost the same as the normal population. And there was no mortality happened in this review. And this was confirmed by this review that was done in the New York City hospitals and was published in the American Journal of Obstetric and Gynecology. And they found no increased maternal mortality with the COVID-19. However, with that quite recent evidence of which is a systematic review that was published in the British Medical Journal last August, and they reviewed a 77 study and more than 11,000 pregnant patients, and it was found that the odds of ICU admission and invasive mechanical ventilation was increased significantly in the pregnant patient with COVID rather than the non-pregnant patients. Okay, let's speak about the ICU management of the pregnant with COVID, and let's start with a case study. We have a pregnant patient, a 39 years old female with gravida 6 para 2 plus or minus 31 weeks of gestation, and she's complaining of complaining of worsening of non-productive 5 days of worsening of non-productive cough and shortness of breath, fever, and malaise. On examination, the patient was breathless and she could not complete a full sentences. She had a persistent non-productive cough, and her vital signs were fever 38.5 degrees centigrade, and the respiratory rate was 32, and heart rate was 100 per minute. Blood pressure was 100 over 60 millimeter mercury, and her saturation was 93 despite 4 liters of oxygen via a nasal cannula. Okay, let's ask a question where we would admit this patient. And of course, we will admit this patient rapidly to the ICU and will form a multidisciplinary approach. Okay, and what are the criteria for the ICU admission of a pregnant patient with COVID? First, the respiratory distress or the increased work of breathing. If the respiratory rate is more than 22 per minute, if the oxygen saturation is less than 95% despite 3 liters of nasal cannula, if the partial pressure of CO2 more than 40 millimeter mercury, or the pH is less than 7.35, or there is a rapid deterioration in the respiratory status. Other causes of admission criteria may be the altered neurological status, the hemodynamic instability, or associated comorbidities. let's go back to our case study, and this is the imaging of our case. We have the chest X-ray and the CT. The CT show bilateral ground glass appearance with areas of consolidation that are typically found in the COVID-19 patients. By the way, could we have the ionizing radiation imaging in the pregnant patient? Is it safe to do a chest X-ray or a CT in a pregnant patient with COVID? And the answer comes from the American College of Radiology and the American College of Obstetrics and Gynecology, that it was shown that if a pregnant patient is uh, confronted to a single chest X-ray or a single CT, the emitted radiation is much low to affect the fetus. However, we have to put a shielding on the pregnant mother abdomen before we could go for a CT scan. Okay, who will manage a pregnant patient with COVID-19 in the ICU? Again, we'll speak about the multidisciplinary approach, where a critical care specialist, obstetric and gynecologist, anesthesiologist, neonatologist, and even other specialties may be indicated to manage a patient with a pregnant patient with COVID. Back to our case study. Upon arrival of the patient to a negative pressure room in the ICU, she was placed in isolation with airborne precautions in the left lateral decubitus, and they have reassessed her oxygen saturation, and it was worsening. It was 78% despite a nasal cannula oxygen. So she was put on non-breathing mask, and the oxygen flow rate was increased to 15 liter per minute. An initial increase in the saturation to 82%, but the patient still complaining of she was feeling exhausted and she was in impending respiratory failure. So what would be the next step for the management? The decision was made to proceed with rapid sequence intubation with mechanical ventilation for this respiratory failure. So we have to ask ourselves, is there any specific strategy for intubation and mechanical ventilation of the pregnant patient with COVID?
There is a children behind. I don't know where it's coming from.
Oh, okay, okay. I'm sorry for that interruption. Is that clear?
Yes, please. Thank you.
Okay. Again, is there any specific strategy for intubation and mechanical ventilation of a pregnant patient with COVID-19? And the answer is yes. Although most of the management of the critically ill pregnant patient is unchanged from the general population, however, there is some modification from the standard of care in order to optimize or to support the physiology of the pregnant patient and to optimize the maternal and hence the fetal hemodynamics. And so here we would aim for a higher oxygen saturation, like higher than 95% of oxygen saturation. Okay. The intubation. Intubation should be considered early in a pregnant patient with COVID. That's because there is an increased risk. There is an increased risk of difficult intubation because there is an increased airway edema, and there is a risk of aspiration, and there is a limited functional residual capacity, and this would lead to easily desaturation of the patient. Intubation of the pregnant woman must be done by a competent professional experienced in intubating a pregnant woman, of course, in a negative pressure room, and all the full personal protective equipment should be wear, and it would be using the rapid sequence induction using a video laryngoscopy. Okay, what about the ventilation strategies? The ventilation strategies is almost the same as the adult in critical care. We will apply the protective lung strategy with a low tidal volume of 4 to 6 milliliter per kg. However, we can target some targets are considered in the pregnant patients, and those are PO2 of higher than 60 millimeter mercury and PaCO2 of higher than 27 millimeter mercury and saturation of higher than 95%. However, permissive hypercarbia could be done in the pregnant with COVID in order to maintain the low tidal volume or protective lung strategy. And failure to apply the protective lung strategy would prompt an clear discussion with the obstetric care team whether to terminate the pregnancy or not. Again, let's go back to our case. The continuous fetal monitoring was initiated, and it would demonstrated a prolonged fetal heart deceleration to 80 beats per minute. And this condition fortunately resolved after intubation and institution of mechanical ventilation and oxygenation. And during this brief period of 5 minutes, there was a plan for emergent delivery, and this was considered. However, the maximal ventilatory assistance was applied for this patient, fortunately, and the condition improved rapidly. Okay. What about the maternal and fetal monitoring? We all know that the rate of spontaneous preterm birth in critically ill population, I mean pregnant population, are high. So continuous fetal monitoring is necessary and essentially during periods of um, a period of critical illness. The close monitoring of signs and symptoms of preterm labor is recommended, and it may require a dedicated, competent professional. They will monitor the uterine contraction, the vaginal bleeding, the loss of the amniotic fluid, and if there is an unexplained maternal tachycardia, hypertension, or increased requirements of sedation, tachypnea, this should prompt a call to the obstetric care team for the evaluation of the probability of the preterm labor. Back to the case again. Over the next 8 hours, the ventilator settings were volume controlled mode. The tidal volume was 6 milliliter per kg, and the respiratory rate was 20 per minute, the PEEP of 10, and the FiO2 was 100%. And so the oxygen saturation was ranging between 90 to 93%, and the BF ratio was lower than 100. And this is considered a severe ARDS according to the Berlin classification. So, could this patient have a prone positioning despite her pregnancy? The prone positioning in pregnancy have been shown to be safe in pregnant patients, even with preeclampsia. However, those were volunteer patients; they were normal patients, apart from their preeclampsia. And also, there are case reports that published in the American Journal of the Emergency Medicine, and it showed that successful prone positioning has been done in a case of H1N1 refractory to the ventilation strategy. Back again to the case. On day 8, which is the day 13 of the COVID-19, and this represents the 32 weeks of the gestation. The continuous fetal monitoring shows a persistent late deceleration of the fetal heart rate. And so, would you consider a delivery in such a patient, and what is the best mode for delivering such patient? Well, the indication for delivery are much dependent on the gestational age, where if the gestational age is less than 23 weeks of the gestation, or the pre-viability, I mean, maternal condition is prioritized for all medical decision. If the age between 23 and 32 weeks of gestation, which is the age of the prematurity, the multidisciplinary approach should be done whether to terminate the pregnancy or to use a tocolytics in order to maintain the pregnancy. If the age of the gestation was higher than 32 weeks of gestation, the delivery is strongly recommended. And of course, delivery by cesarean section is preferred. Okay. Could ECMO have a role in a pregnant patient? Yes, ECMO has been successfully reported to be used in a pregnant patient with COVID. Okay. What about cardiac arrest in a pregnant patient with COVID? If the cardiac arrest occur at or beyond 20 weeks of gestation, or the uterus at the level of the umbilicus, we have to provide an immediate left uterine displacement by either pushing or pulling the uterus off the IVC in order to restore the return of the spontaneous circulation during the commencement of the CPR. And also we have to prepare to begin a resuscitative hysterotomy by the 4 minutes without return of spontaneous circulation in order to improve the attempts to restore the return of spontaneous circulation. And thank you.
Till Prof. Esmat open her video. Dr. Khalid, thank you very much for your excellent informative lecture.
Thank you very much.
Thank you, Dr. Khalid.
Thank you, Dr. Esmat.
Dr.
Yes,
Esmat's here now. Okay, thank you.
yes, thank you very much, Dr. Khalid, for your informative lecture of the event of the hour. And we have 10 minutes for questions. If anyone would like to ask questions, please.
The first question is from my colleague again. Does the long-term outcome of prone position exist?
What is the mean by long-term outcome?
Um, because I believe I don't know what it means, but I believe that prone position is utilized in non-pregnant people. So I believe, yeah, some other person ask, do you prone these patients, pregnant woman?
Yes, and we have tried this in our Qasr Al Aini, although limited, very limited resources, and we have tried successful prone positioning, and we were able to extubate a patient after, I think, about 5 days, 3 to 5 days of prone positioning.
Okay. Another question from Dr. Asma Orabi. Thank you very much, Dr. Asma, for this interesting question. What about non-invasive ventilation in pregnant women?
Okay, well,
Thank you. Very
this is a very
interesting.
good question. The non-invasive ventilation, although it's successfully reported, the use of the non-invasive ventilation, whether by the high-frequency nasal cannula or by the non-invasive mechanical ventilation. However, in such pregnant patients, I would rather be more convenient with yearly intubation and mechanical ventilation. That's because the physiological changes of pregnancy that hinder the intubation and mechanical ventilation difficult. And so if you are going to use to intubate such a patient in a situation of emergency, it would be very difficult if the patient was difficult intubation. And so early intubation, I think, is better than the non-invasive ventilation. However, it has been reported a successful use of the non-invasive mechanical ventilation. And also, the non-invasive mechanical ventilation carry some risk of um, more pollution and increasing the risk of infection to the others.
Okay. There is another lecture, another question here from Dr. Muhammad Mahdy Gaber. Thank you. Blood transfusion and the fluid resuscitation, if major bleeding expected, any precautions?
That's for a pregnant or for the anesthesia, for the pregnant
Um,
intensive care or for the anesthesiologist.
I believe from for anesthesia.
I think, however, blood transfusion, we have the good thing about the blood transfusion. I think there is no major change. We have to consider keeping the hemoglobin level above 7.9 if the patient was a little bit unstable. And also the reservation of packed RBCs and other blood products would be very important. That's because those patients commonly are on anticoagulants and a large dose of anticoagulant as well. So we can expect a major bleeding to happen, and so we have to reserve packed RBCs and all the other blood products.
There is a question here from Dr. Hadia Ahmedet. I don't really understand what does she mean. Thanks, Dr. Khaled. The 4 or 5 minutes are considered mythical. I don't know. We can extend up to 15 to 30 minutes. What's your thought about this? I don't know.
Well, I realized that she might need to increase the time permitted for them to interact or to ask, I think.
Okay, she here I meant resuscitation hysterotomy.
Okay.
The 4 5 minutes rule, lots of emergency doctor considered is mythical.
Okay. What
I
I
don't know.
what I understand, I
I
do
don't
not
know.
understand, but I think she is talking about could we do a 5 minute resuscitation hysterotomy in 4 minutes? She might, yeah, it might be a very short time, I think.
Excuse me,
However,
Khaled, I'll discuss this in my lecture.
Okay.
okay,
Also, more things to say.
I know,
Yeah, I'll answer all
but
these.
all you are needing is a scalpel, into just a scalpel.
Prof. Nesreen, you can start your video now.
Yes. Thank you, Dr. Khaled.